Yeah.
Uh, I'll wait some persons getting in our meeting, and I will start with a few words uh, in a quick announcement in Portuguese, and then I let you know when we will start,
Okay.
please.
Right.
Okay.
So I'll put that for now on mute and in 5 minutes, you said.
Yes, great idea. Okay. André?
Salve, salve.
Ô, bonitão, não vi que você estava aí. Desculpa. Tudo em
Acabei de
paz?
responder para você, não grita no seu WhatsApp.
Ah, então tá bom. É verdade. Tá bom. Como é que tá aí? Tudo bem, amigo?
Vivendo um sonho.
Então tá bom. Mas o Angel também tá entrando e o Mil deve estar dirigindo aquele carro louco, né? Nas
Ele
ruas
tem
de
um carro novo?
Brasília, atropelando alguém no meio do caminho. Acho que para não atrasar tanto ele, eu vou fazer já os avisos aqui. E aí a gente não perde tanto tempo aqui com.
Boa.
Vamos lá. Bem, boa noite a todos. Nós estamos aqui num Painwine especial aqui com o Dr. Leonardo Kapural, que é uma pessoa especial. Não precisamos nem muito é, anúncio sobre seu currículo, nada. Uma pessoa muito importante no mundo da dor. É, nós temos aqui alguns anúncios antes de começarmos. Um deles é falar aqui com o pessoal da mesa, agradecer de novo a presença deles, Andrezão, que é nosso sócio aqui, Cissa, tá com mudo, eu já te libero aqui, Cissa, para você também falar.
Fala, Manuel.
E, e outra coisa é agradecer a OMED, que é a nossa patrocinadora, já vem apoiando o nosso canal há muito tempo, e falar um pouquinho das coisas aqui sobre a mídia. Nós temos aqui o Tratado de Dor Pélvica, que está no pré-lançamento ainda, e ainda tá seguindo os descontos que nós já demos aqui para sócios, descontos para quem foi no Congresso da Sobramid, para quem foi no Lagos Dor, para vários aí eventos no ano que já participaram e que estavam alinhados com o evento, por exemplo, o Isura, que também tem desconto na compra do livro. Ele deve ser lançado aí em novembro, oficialmente, mas está nessa fase de pré-lançamento e está com desconto para pessoas que a gente acabou de falar. Eu tenho também um anúncio importante aqui para a Sobramid com relação ao apoio dela no nosso workshop do exame do FIP e do CIPS, que são os exames de provas aqui do Instituto Mundial de Dor, que vão acontecer tanto o workshop quanto a prova de 13 a 15 de março do ano que vem. De 13 a 14 são os 2 dias do workshop e com grandes vantagens. Nós queremos envolver toda a América Latina, não só o Brasil, e vai ser um evento que vão ter aí já autorizados aí pelo menos a prova oral e a prova prática nas 3 línguas, que é o português, espanhol e inglês. Só será a prova escrita em inglês, mas as outras provas todas serão nas 3 línguas e será a primeira vez que o exame acontece na América Latina. Então a ideia é integração, é fazer aí um trabalho muito bonito para podermos aí ter um exame cada vez mais próximo da gente e da nossa realidade, tá? E aqui as pessoas da mesa vão estar participando, o André, a Cecília, do evento com certeza. Falando isso, eu já vou falar um pouquinho do currículo do Dr. Kapural, que é o diretor clínico da Carolina Penn Institute em Brookstown, Wake Forest Baptist Health, professor de anestesiologia, na Escola de Medicina de Wake Forest, diretor-geral da Sociedade Internacional de Neuromodulação, diretor também clínico da Carolina Penn Institute Brookstown, como eu já disse, tem inúmeros trabalhos, vários prêmios no mundo todo. Então é com muito orgulho aqui que a gente tem o Kapural. Deixa eu ativar o som dele aqui. Dear Kapural, thank you so much for coming here to join us this evening. It's a big pleasure for us. And you are very special for our physicians in Brazil and all Latin America. And in our board, you have André Mansano, Cecília Nobre, you have Angel from Mexico too, and the attendees, I just saw Sudhir Diwan is here with us too.
Yeah.
Thank you so much. We are all curious. I'm not because I saw your wine, but we're curious about your wine too, man. Thank you so much, my friend.
Yeah. Thank you, Jose. I appreciate having me. I feel like with the friends, with Andre and Cecilia and Sudhir and you and everyone else on online, kind of going back to Brazil so many times. We have the same mentality as I have as somebody from Croatia. You know, we have this kind of different, more social kind of ways how we deal in everyday life. Yeah. So that's why I wanted to introduce and for you who already try it, one wine that has to do something with Croatia. So let me see how I can. Here we go. So this is Girgish Hills Napa Valley Chardonnay. It's 2022, and so it has a very distinct taste. And what you have to realize, see that little, I don't know if you can see it, but there is right there this is also on Croatian flag, you know, that checker. Yeah. So the guy who made Napa famous, Mike Grgic, grew up in the area where I came from, in the middle of what is called Dalmatia or Dalmatia. You know, Dalmatian dogs and, you know, the nice coast and sea and olive trees and stuff like that. And so there's lots of wine made there. And so he, with quite knowledge of making wine as a very young man, joined Mondavi in Napa and started making some really good wine. How good? Well, that good that first time ever he won a first prize in blinded Paris tasting. For 100 years, none of the wines in every category except French won the first prize. And he won it for this wine, for this Chardonnay in 1976. So the movie was made about him. There's a Hollywood movie how he returned back to Napa, and like 10,000 people were carrying him through the Napa after he won that first prize in blinded tasting in Paris. So that wine became refined, and I love it. It's really well. If you read this aroma, I don't know how to describe it. I have a decent cellar, maybe by 400 bottles down in my cellar all the time, but I think it's like a really Napa Chardonnay. Maybe a little bit more of a depth, a little bit more of strength, but also it's fruity. It's not too oaky. I think it's a really nice bouquet. Anyway, cheers everyone, and for all of you who. So
Cheers.
So Leo, I have a question for you.
tell me.
Has this wine been Americanized after it moved to Napa?
Well, I mean, he made this not one in Napa. He worked for Mondavi, so
Oh.
he left communist Yugoslavia under pressure. And he was 100 years old when he passed away 2 years ago.
Yeah.
Mike Grgic, yeah. So he also is very instrumental of discovering how Zinfandel came to California. The lady, I don't know if you remember, but there was a Napa Pain Conference. We had lectures from that lady who is an enologist and PhD from University of California, San Diego. And she went to France for 5 years trying to, with DNA analysis, to find out the source of the Zinfandel wine in California. And eventually, after going to 1 year in Italy, looking at the Primitivo, which is really far cousin, eventually Mike Grgic actually directed her to backyard of my hometown, Split. And she had the perfect DNA match. And this is the first ever publication with the bands, like a real basic science publication published in insert of Wine Spectator, believe it or not. So Mike did lots of good things, as far as the figuring it. But he worked for Mondavi. He did phenomenal job. And then he made this with investor David Hill. They make Grgic Hills. And this is now institution in Napa, about winery. It's big winery, but makes very exclusive cabs and Chardonnay. I love their Chardonnay. I think it's very
Good. Yeah. Thank you,
anyway.
Leo.
So Jose and everyone. So we're gonna move then from Chardonnay to why we're here tonight also. And this is what is new in spinal cord stimulation, and a little bit about new indications. So what is new in general? And I really wanted to give you some overview of second generation spinal cord stimulation systems, mainly closed loop systems. This is now made by Saluda from Australia, but also by Medtronic. And then very interesting approach, which is called multi-phase therapy from Biotronic in Germany. Also, I'm mentioning glial cell stimulation. My good friend Ricardo Vallejo, that did a phenomenal job, and I'm proud that I was able to help very early in development of Steamgenics. Really did a great job in providing this DTM type of stimulation that is now on Medtronic platform. But also, I'm gonna look at the third generation spinal cord stimulation system. We are embarking and starting next month with the ultra low frequency spinal cord stimulation FDA study. This is very interesting approach because it uses very low frequency of 2 hertz and very large pulse width with an enormous amount of the charge. So really, they cannot use conventional electrodes, but they use change metals in contacts, electrodes that cannot heat up. Also, what is really characteristic of ultra low frequency spinal stimulation is that it takes care of the nociceptive pain as well. So in one shot, you take care of the back pain, discogenic neuropathic pain, mechanical lower back pain. You take care of the facet and SI joint pain in the same patient. And that was the really key for us for many years, because you will implant a stimulator and you will get a good relief when it comes to neuropathic and discogenic back pain, but really, and lumbosacral radiculopathy, but very little improvements when it comes to other mechanical or inflammatory pains. And then the other one, which is called ultra high frequency spinal stimulation, which we got approval by the FDA to initiate the study. It's still being on hold. And that ultra high frequency stimulation, which is really interesting, provides pain relief for about 4 days by stimulating only 7 minutes. So it does not require implantation of the generator. It has only antenna, and generator stays in the patient's hand, and it's placed right there underneath on the skin where the RF system antenna is, and basically stimulating for 7 minutes that way for pain relief for 4 days. Also, something about new indications, non-surgical refractory back pain. Please pay attention. We finished 5 randomized prospective trials. I was fortunate to run the first one with Nevro, 10,000 hertz. These are the patients who are deemed not to be surgical candidates by a spine surgeon, but they have significant back pain. There are another 2 studies by Medtronic, and one by Abbott and one by Boston Scientific, and all of them are showing profound improvements in the pain score. So we tend to believe that spinal stimulation, if there is no weakness, if there is no instability like in spondylolisthesis, should be early option in treatment of back and leg pain. Chronic abdominal pain, that's sort of my early work, and we are very pleased that we did some of the initial ID data with the FDA. We are now preparing to do another one, hopefully for approval by the FDA in the United States, and then pelvic pain. So a little bit about first 10 kilohertz and where we came when it comes to non-surgical refractory back pain. As you know, 10 kilohertz spinal stimulation back from 2013 with the Adnan Al-Kaizi study, European study on 10 kilohertz provided evidence that high frequency as a first-time breakthrough waveform double the improvements in the pain scores compared to traditional low-frequency paresthesia-based stimulation. And we published 12 months and 24 months data, and I was honored to be the principal investigator, providing evidence also in direct comparison to low-frequency traditional paresthesia-based stimulation that we were able to provide twice as much pain relief and improvements in functional capacity. Same thing later on, we showed that if we switch patients who already have been on low-frequency traditional paresthesia-based stimulation for years, and they failed in improvement. So those are the patients who had sometimes 2 or 3 years stimulators off because they, what we call silent explant, because they were not using it. When we switched them to 10 kilohertz spinal stimulation, 81% of them had more than 50% of the pain relief. This was done with University of Kansas, and we were really happy to see those kind of improvements, even in the patients who had a previous different system. Well, for non-surgical refractory back pain, this initial study that led later to other studies, we were able even to publish the actual design. I think that reviewers consider this pragmatic design valuable, comparing this to conventional medical management and providing the crossover. So these are all of the patients accounted for the study. Trial success exceeded 90% of the patients with more than 50% pain relief. And then we did the crossover, about 86.6% of the patients elected to cross to 10 kilohertz from conventional medical management. And again, they had similar trial success of almost 94%, 61 out of 65. So we are very pleased with the results of it, as well as the other waveforms used for this type of refractory back pain. If you look at the long-term data, again, we exceeded 80% of the patients with more than 50% pain relief, and we were really pleased with the results. If you look at the crossover patients, as soon as they crossed over, the reduction of their pain scores was similar to those originally implanted patients, and you can see that this extended through the 12 months follow-up. Improvements in functional capacity, similar. Original improvements led from severe to moderate disability to minimal disability. As you can see, also those patients who cross over, they also had a similar improvements once when they cross over to spinal cord stimulation. Patients who were on opiates, they were able to reduce their opiates almost by half in 10 kilohertz stimulation group. And then peripheral neuropathy in diabetes with using 10 kilohertz run by Dr. Peterson, a good friend and neurosurgeon over in Arkansas, provided also evidence that the improvements in the pain scores when it comes to peripheral neuropathy in diabetes were much, much better than we can provide with any of the medications that we use today. For example, gabapentin, number needed to treat is 7.2. So you need 7.2 patients to achieve more than 50% of the pain relief. That mainly relates to either side effects that like sleepiness, dizziness, problems with the balance, excessive forgetfulness, or just not achieving 50% of the pain relief. Well, if you look at the PDN study, peripheral neuropathy in diabetes, number needed to treat was 1.2. So it has been suggested, and lots of us think that we should use spinal cord stimulation much earlier in a treatment of peripheral neuropathy in diabetes. And the crossover again showed that the similar results were achieved when patients went across to the 10 kilohertz spinal cord stimulation. When it comes to abdominal pain, chronic abdominal pain, again, our ID with the FDA was with the with 10 kilohertz spinal cord stimulation. We use Nevro device. Idea was to treat visceral hyperalgesia rather than just abdominal wall pain or entrapment syndrome, and we did. I thought that we did fair assessment. We also did splanchnic block as a sort of criteria. Those who responded to splanchnic block with more than 50% of the pain relief were considered candidates to go with the spinal cord stimulation. So these are the few studies that we published back, and I think that indication is still there. Consider patients that you have that had resection of the bowels, resection of the colon, post-cancer, the Nissen fundoplication, gastric bypass surgery, and maintained pain, intra-abdominal pain feels deep, worse with the eating. Also those who have dysmotility syndromes like gastroparesis or severe IBS, all of these patients, and chronic pancreatitis, all of these patients were treated with spinal cord stimulation. And with the idea with the FDA, we were able to provide evidence that over 12 months, we were able significantly to reduce pain scores in that subgroup of the patients, mainly placing the leads at about top of T4, is stimulating with active contact somewhere in the mid 4, lower 4, top of 5. Also, in another article summarizing the data from dysmotility syndromes, we were able to show that not only that we can decrease the pain, but those patients who have severe gastroparesis, we can reduce their nausea and vomiting as well. So this is from the ID with the FDA, smaller group of the patients that had gastroparesis, post-surgical, chronic pancreatitis, and 2 of them even abdominal wall pain, maintaining the pain scores down at about 2 from about 8 in average over the extended time period over a year. We did well. There were more infections that we would think of. There was 1, and we replaced that patient, and then almost everyone, 96%, had a successful trial and went for an implant. Improvements in the functional capacity were significant, again, from severe disability based on PDI index, went down to moderate or minimal. But what's really interesting is that we were able to reduce vomiting, nausea, fullness, and bloating. Those parameters we as a pain guys never look into. I asked my GI colleagues, what am I looking at? And they say, okay, well, bloating is very important. I had no idea, but we got that one, and we got quite improvements that we were proud of when it comes to abdominal pain. I'm going to talk a little bit more about the new waveforms. This is an interesting one. I'm not sure. I don't think that is right now in Brazil, but hopefully will come soon. Biotronic is international company that is headquartered in Germany. However, they still don't have approval in Europe, but they have it in the United States. I was happy to do their Benefit 2 study, which was temporary stimulation for 21 days. And I got very familiar with what is called multi-phase stimulation. Basically, if you think about all of the either high frequency, low frequency, fixed output stimulation devices that are out there, the stimulation of the therapy or series of those stimulation phases followed by, they have to be followed by charge balance on anode. So the stimulation here in multi-phase stimulation, it has a simultaneous charge balancing. So you activate multiple electrodes with very quick microseconds time, and then you charge balance on the next array of the electrodes. That way you activate a large area over a very short time period. So, and it's very interesting because I guess adding to charge, like I mentioned before, with ultra low and ultra high frequency pays off when it comes to improvements in pain score. So this was the design of that Benefit 2 study. Basically, we used other commercial devices, and then we went on and used multi-phase therapy with 2 different frequencies. And what we found, and we published that a while ago, is that improvements actually with the multi-phase were better compared to all of the previously trial either or commercial participants that include high frequency and burst and the low frequency stimulation. So this is what we did when it comes to design, and this is the change from the baseline. It was quite significant. Again, the yellow line is multi-phase therapy. The black line is improvements from conventional management. As you can see, we were able to niche somewhat better improvement over that week of stimulation with multi-phase therapy compared to every other treatment that we use commercially. And so we were pleased with it because not only that improvements in the pain scores and function were significant, but also patients were very happy. They also improved sleep significantly, and we felt that it was a great study in order to pursue next step, which was the implantation of the device. Keep in mind, this is a brand new device, German engineering, well done. They work on design for like 5 years. We had one after other advisory board just talking about how to design anchors, how to design battery. The battery has highest level of MRI safety. They have 12 Tesla magnets in Oswego Bay, next to Portland. They're testing their devices. I never seen 12 Tesla, and I was really hesitant to come close to it. I was just, okay, you know, you guys, whatever. But they show us the area and show us where it is. Interesting. So they did lots of basic science too before they embark on their system. Benefit 3 study was completed in Australia, and I was the monitor for the study, so I'm very familiar with the data. It included not only multi-phase therapy, but also remote device monitoring and programming, which is really interesting. So patients do have app on their phone, and they can initiate reprogramming of the device. If there is something else that they need to do about the device, they can also call up on the person who works with Biotronic, or they can directly connect to us in the office. So that's really nice. So, and you would know all of the folks who are there, including Mark Russo and Paul Varillis, and when it comes to patients, clinics and patients they implanted, they followed the patients for a whole 24 months. And regular trial, single-arm study, looking into patients that have chronic low back and leg pain. And they look at the pain scores and functional capacity. With the proactive care, the system was set up before. There was lots of discussion about how this process takes place to satisfy HIPAA rules and patient privacy and everything related to communication with the physician. So there's lots of automated programming, but also there's also support from study remote specialists, and then related to the clinical side. So all of those were activated if needed. So again, these are some of the characteristics of the patients. I'm not going to go through this. It will take me too much time, but this is a 12 months improvement. Majority of the participants had more than 50% of the pain relief. And we had we had more than half of those patients who were what we call complete remitters with more than 80% of pain, which was kind of very, very interesting. So sleep, also a steady disability index, and very few side effects were characteristic of the study. Also steady improvements were really most of the patients went to minimal disability. So again, very happy with the results. What is really important to say is, and if you just recall any of your patients that you implanted device, it takes a while to fix it. Let's say that the device stopped working tonight. The patient still needs to call, set up the appointment, they call the rep, they see what they can do. If they cannot take care of the problem, it usually takes days, sometimes weeks, to see that patient. The problem is the pain gets worse. The patients, sensitize more. You need to intervene and do so much more if you leave the patients for weeks with significantly increased pain. So in Benefit 3 study, it really was proactive treatment where the time from the event to the issue resolution is very short. It's really only about 2 days, which is really, really important to emphasize. And then I need to mention now, moving on to 2 closed-loop systems that we have now. One is Medtronic system, and the other one is Saluda that started first, providing the closed-loop system. I think it's extremely valuable. I think we have some really good data to support that. And why is important? Well, this Scott Pritzloff study that was published just recently in Pain Physician kind of hints why is important to maintain this stimulation properly all the time within a therapeutic range. Well, they look at the 100 patients that were implanted And they look into how these patients are doing. Either they have paresthesia-free, most of them, or paresthesia-based stimulation. And as you can see, lots of these patients claim that their stimulator may be too strong for some activities, like shocking, tingling. Even if they have paresthesia-free stimulation, they feel that they can experience overstimulation. Well, the problem there is what they do, they decrease the amplitude. And they go off the therapeutic range, and they're not getting pain relief that they're supposed to get. Similarly, if you look at the some of other, about 35% think that is maybe too weak for some activities. So, and again, readjustment, when it takes place, when we shock them, they will go back and forth with the increase or decrease of the amplitude. So, not only that, there's a significant component of avoidance. They don't want to exercise. They have issues with coughing, doing house things around the house, walking, laying down, laughing, and so on, because they will get some shocks from the stimulator. Even when the stimulator is subthreshold type of stimulation, like you see with the burst, DTM, or 10 kilohertz stimulation. So so obviously the problem is that what they do, basically, they talk into their rep first, or they call the office and they need to discuss what can be done. The issue is that this communication sometimes is, again, delayed, and then others just need so many visits to the office just to optimize programming of stimulation. Never gets to the point where it's supposed to be. So the closed loop type of stimulation may resolve those issues. And two systems, one from Medtronic and one from Saluda, are out there. Saluda started first with the Evoke system. Very interesting optimization of the stimulation by using evoked compound action potentials to optimize the therapy. Now, what are the evoked compound action potentials, or ECAPs? Well, this is imagine this as allows the extracellular stimulation from dorsal column. So underneath you see the waves that show you movement of the action potential. Obviously, this type of ECAPs, and I know that I did my PhD in electrophysiology in neuroscience, and I work on whole cell and single channel recordings, and I did my thesis. And it's extremely difficult to do extracellular recording in a fixed sample of the tissue. Moreover, even more difficult in fixed animals. Can you imagine walking human and recording 4 million times a day from the dorsal column and readjusting the waveform based on movement, responses, laying down, sitting up, and so on? So if you look at that Prislov article that I just mentioned, you can eliminate all of these issues related to changes in position, coughing, exercising, doing anything, because the ECAPs with a closed loop type of stimulation can be properly adjusted to the certain level. And we know now which level we should be at in order to get proper type of optimal therapeutic range. Even more precision of the very nicely filtered waveform can be adjusted in order to, provide us with plus minus few microvolts adjustment at every single stimulating beat. So this is a system, yeah. So we can stimulate the target nerve from one end of 12 contact leads, and then we can record ECAPs back about 4 million times a day and adjust accordingly therapeutic range. This was the Evoke study. the first double-blind RCT, and it was done in the United States. There were 13 US sites. I'm proud to say that we were one of the sites, and I did the first implant in the study, which I was really happy. Got a picture a little bit with, like number one. It was a big deal for us because we really loved the stimulation. I did the temporary trial before EVOKE study, where we had a beautiful improvements in pain scores in those patients that maintained stimulation all the time and really didn't care how they change position, what they do. They were always and happier. See, if you imagine any sub-threshold or above the threshold type of stimulation, when it's fixed output. Let's say they lay down and watch TV on the couch, and they feel overstimulation. Either this is sub-threshold and they feel that something is, squeezing in their back, or they feel more paresthesia. If it's low frequency, traditional paresthesia-based stimulation, what they would do, they would drop it down. And then they are below the therapeutic level for a while. It's like taking gabapentin once a day instead of 3 times a day. You just miss those many hours of the therapeutic stimulation, and eventually pain comes back and gets worse, and then they turn it on again. So this avoids all of this issue with optimized care that goes 24 hours a day. So not for we were not surprised to see that there were 83% of the patients who had more than 50% pain relief, 60% of those who were complete responders, and then patient satisfaction was really high. We work on some of the biomarkers later on, looking at how we can optimize dosing, and we figure that if we adjust the ECAP amplitude just above the 1.4 above the threshold of activation of the ECAPs, we will be able to maintain proper therapeutic range over extended time period. Not only that, but we can actually determine the actual range in microvolts that will maintain this over extended time period. And this was the topic of recent study, but we actually did correlation between optimized neurophysiological measurement and improvements in the patient scores and functional capacity. And there are more papers. These are all articles published on that topic. So I think we have quite a bit of the evidence that neurophysiological optimization and objective assessment using ECAPs does provide information that relates to improvements in the patient scores and functional capacity. So Medtronic just started recently. This is from another neurosurgeon that I really like and respect, Wahid Mohabadi from Australia. They did another smaller study, single-arm study, using closed loop, but then with multiplex spinal cord stimulation. So DTM plus closed loop seems to be a winner. And it was pretty good. The only thing is the time interval of this inceptive study was relatively short. It was only 3 months. Improvements were profound. The maintenance of the closed loop was independent to DTM, because DTM is subthreshold, different frequency. And then they had to run below that, low frequency, 50 hertz, the paresthesia-based stimulation in order to capture ECAPs. Still, improvements were great. From open loop to closed loop, you can see that not only that you can eliminate overstimulation, but you can also provide really decent pain relief, and that will extend to at least 3 months that they studied. You see the reduction in the back and leg pain. Also, you can see improvements in functional capacity here. And so this is really the next step. I think that Medtronic is getting little by little there where Saluda was already when it comes to filtering, optimization of the ECAPs. But I think that's a good way. Initiating competition like this, I think, will bring us to the next level of optimizing ECAPs. I'm looking at some of the other things that I think are important. What's underneath the curve and how to analyze that and how to see if you wean the patients of opioids or change their membrane stabilizers like gabapentin or Lyrica or trileptal, Zonogram, sodium channel versus N-type calcium voltage-gated channel blockers, how the ECAPs change. And is that predictive of what we do in the future when it comes to weaning the patients of medications during the spinal cord stimulation? There is a little evidence for it. Let's see what happens. This is my favorite. So this is my the most favorite future of the spinal cord stimulation. We are all optimistic about it. Let's see what happens. I mean, the study, we literally starting next month, first implants. So the ultra-low frequency neuromodulation was patented by a group of the physicians and researchers around the company, which is called Presidio. They are in San Francisco. They early asked us to talk to them about their initial laboratory data. They were impressive. They basically said, okay, we remember that Hodgkin and Huxley Nobel Prize in Physiology back in 1963 was actually discovery in inhibition and excitation of peripheral and central portion of the nerve cell membrane when it comes to using electrical power. If you use short pulses, they will excite neurons by activating sodium channels. And that's what nowadays we do with all of these stimulating patterns that we are involved when it comes to low frequency, high frequency stimulation fixed out. But ultra long pulses can inhibit neurons by inactivating sodium channels. And really, it was abandoned in 60s. And it really didn't justify the cause. You see, yes, you do get motor block. See this muscle that has been stimulated? See? As soon as you apply long pulse, ultra low frequency inhibition to the nerve, the stimulation ceases. Well, if you're applying this to the dorsal column, it's different than when you go into anterior spinal cord. And you can actually modulate signals. You can provide neural inhibition, and you can avoid motor blockade. The only problem is that, and that was concern, that we would overheat posterior epidural space and cause neural damage with electrodes like this. Well, that can be also fixed, and they did it. They changed the metals inside the electrodes, and that way they were able to safely stimulate. You can see histological findings first in animals, and then again in Australia, another study in humans. Improvements were quite impressive. I mean, literally from 7.3 to 1.8, but they focused not really on neuropathic back pain. They focused on spondylosis with sacroiliitis, discogenic and mechanical back pain. And those are the patients that they describe here, which is quite impressive. And those are the patients that we are going to enroll now in the FDA study. So we're looking forward to see how this is going to play. I think it's going to be, I mean, lots of us believe, based on these initial data, that this is going to be breakthrough therapy, third generation of the spinal cord stimulation system, same as the ultra high frequency. This is 500,000 hertz. you do use this in Brazil. It's called pulse radio frequency ablation. So pulse radio frequency ablation, when you go to the DRG, modulates the signal, but it gives a couple of weeks of pain relief. It doesn't give prolonged relief, but relief is good. Same thing as you go to the dorsal column, it can do the same thing. And these folks from Taiwan, Jimer Medical, figured that one. I went with them first to the FDA with the design of the study to stimulate dorsal root ganglia. We got approval, and they said, we're not going to do DRG. We have already data from Taiwan that it works on dorsal columns. If we apply 500,000 hertz through 8 contact leads to T9 level midline, we are able to achieve profound pain relief just by stimulating 7 minutes. And the pain relief went on for 4 days. So we felt, they said, we really don't think that DRG is the area that we're going to go first. We're going to go to dorsal columns. We went back to the FDA, got approval again. Design of the study was nice, sham randomized prospective trial. We published actually design, but the company eventually put on hold this effort because they're working on a small non-invasive peripheral device, which is called STIM-ON, and is being now sold quite a bit in China. So these are some safety data. Again, the thought was that maybe 500,000 hertz can cause some damage to the spinal cord. That this was not true. The histological data were nice and clean. No significant difference in any of the stains that were provided. And again, the small group that was initially trialed in Taiwan showed that temporary trial could provide 80% of the pain relief in those patients for 4 days. So definitely there are new waveforms and probably we should stay away from just tonic, fixed, paresthesia-based, low-frequency stimulation, because there are now at least 9 studies that I know comparing any new waveform to traditional spinal cord stimulation. This traditional tonic paresthesia-based stimulation was always inferior, with only 40% of the patients with more than 50% pain relief. I think that if you look at the 10 kilohertz and burst stimulation and DTM, that second generation of the waveforms provided evidence, and the closed loop provided evidence that improvements in the pain scores not only were profound, but they were able to maintain over extended time period. 2 years and 5-year studies were published. Still, however, I do believe that ultra-low and ultra-high frequency stimulation will be a phenomenal addition to what we do nowadays. And not only that will help more patients with inflammatory pain, nociceptive pain, but it will also probably be much more practical. Like if you look at the ultra-high frequency, if you have to stimulate only 7 minutes and the pain relief is 4 days, that generator is forever. So again, it remains to be seen. I'm looking forward to this ultra low study, and hopefully we'll be able to get also ultra high back to FDA trial as we originally planned. So, thank you very much. Thank you, and cheers. Yeah. Let me get some more. That was a long talk, Cheers, Andre.
Yes.
Everyone was.
Yes. Congratulations, Kapural.
Thank you.
I'm surprised about your wine again. I really enjoy the wine. And just to complete what you asked, we don't have yet Lopi Voki in Brazil. And the 10 kilohertz neuromodulation, we don't have it the same. But the closed loop will start the end of the year from Medtronic.
Right.
And I would like to ask about in your particular use, what kind of modulation do you prefer for three diseases like back pain, fail back pain, pelvic pain, and leg pain, neuropathic diabetic pain?
Yeah. So, I mean, if you ask me what I'm doing this month,
Yes, please.
last 3 months, that I'll tell you, I use for peripheral neuropathy in diabetes and certain mononeuropathies. I use only 10 kilohertz. I use never. The best results. It's sub threshold. It's profound relief, and not only that, but it seems to also provide the best modulation of the decrease of this numbness, so they regain some feeling. That's number. And number two, significant increase of CGRP, the glucose level, the glucose control in diabetes gets to the normal level, and they can get off their medications. CGRP increase is profound with 10 kilohertz. And this is the secondary peptide that affects the beta cells in pancreas to produce more on endogenous insulin. So that applies only to type 2 diabetes. When it comes to more of the chest pain, wider areas that I need to cover, and safety in patients with the cancer, so MRI safety, I use Biotronic multi-phase. It's extremely effective to cover wider areas of the pain. And it's technically the best device that we ever had. When it comes to belly pain, I initiated now, investigator-initiated study. We are now leading to the, hopefully, IDE. I use closed loop with Saluda. Very interesting. Very interesting. We really had such a great results, not only for visceral hyperalgesia up here, responsive to sparking block, but also in pelvic area responsive to superior hypogastric plexus. Pelvic floor, I use DRG with Abbott. I do S2, S3 for pudendal neuralgia and any pelvic floor issues. We did very well with those two. So that's pretty much what I use nowadays. Like last 3 months. It may change next 3 months, especially when it comes to new studies. Yeah.
Thank you.
Sure.
Thank you so much, Leo, for your lecture. Regarding those rescue study you present in the beginning of the lecture, which evaluates rescue therapy with high frequency stimulation, I guess the electrodes was replaced. Yep.
So yeah, so what in some of these patients, electrodes were not replaced. It's interesting. Actually, most of the patients, we had 105 patients, and some of them needed replacement of electrodes, but most of them just had replacement of the generator. Namely, they have adapters now for every system. For example, Boston Lead connect directly into Never generator. Abbott system has adapter to the Nevro generator. Medtronic same. So now every single waveform, they have some adapters. So you can switch.
Very interesting. Thank you so much.
I think it's very interesting because it's not only mine. This was a study just looking into low frequency traditional paresthesia-based stimulation moving to 10 kilohertz. We have now studies that other waveforms were tested, going from one to another, and it seems to be efficacious. So we haven't got to the bottom of this. Why, how, and what are the indications? But I think it's an interesting step toward providing better relief over extended time period. So,
Right.
Thank you so much.
Dear Sudhir, do you have any questions?
No, I think There's so much to learn from Leo. It's a wonderful presentation, and I learned something. Now, did you say biotronic or you said Medtronic? Biotronic.
Yeah, Biotronic was, as far as the design and quality, is really, Medtronic has a great system.
The
Don't
remote
understand.
control.
Yeah, Medtronic has a great system. DTM is a nice waveform to use, especially with a closed loop. Biotronic multi-phase was quite impressive in that initial temporary trial. And then as I monitored the Australian study, I was the one who was checking everything, you know, side
You're
effects
the
and
monitor,
everything
yeah.
of the guys. And I was super impressed how much improvement over 2 years these guys were able to achieve. I think Biotronic is on something really good. And
And this
they
can be reprogrammed remotely, correct?
yes, this program is this patient initiates on their app, and it's program goes directly to Berlin, and
Yeah.
they program device anywhere in the world. The
And
nice
that's
thing,
one device I haven't used yet, and I'm looking forward to.
yeah, I think it's a great device just because there are two great waveform with a profound improvement, but then you add with that remote programming to it. So again, um, I use them for, so let's say intercostal neuralgia, multi-level discogenic pain with a wide area of the back that needs to be covered, you know, those kind of indications. And I did really well.
Fantastic.
Yeah.
Okay. Cissa,
That's why we love you, Leo.
Thank you, Sudhir. Love it. Always, always, always pleasure to see you, my friend. I'll see you in a couple of weeks.
Yeah. Next week, my friend, not couple of weeks.
Oh, next week. Sorry.
Next week, yeah.
All right.
okay. Any more questions?
No, I think that's fantastic.
Okay.
Yeah.
Thank you so much, Leo.
All
Thank
right.
you.
I appreciate and love you guys, all my colleagues and friends in Brazil. Always pleased to talk to you anytime.
Yeah.
Please, we definitely love to participate in any of the discussions.
Brazil is the best. All right. See you guys. Thank you so much.
Thank
Pleasure.
you. Bye.
Good night. Good night.
Bye.
Thank you.
Thank you. Bye-bye.